When a patient has a persistent skin eruption that is not cleared with a typical topical treatment, we should consider that this condition may be Mycosis fungoides, or MF. There are common skin conditions such as psoriasis and atopic dermatitis that are often confused with MF, but those usually have presentations that would help distinguish them from MF. For example, a patient with psoriasis would typically have a certain distribution of lesions, such as on elbows, knees, and nail involvement. A patient with atopic dermatitis usually has a history of widely distributed scaly patches and doesn't usually have plaque involvement. The distribution of lesions in MF is helpful for diagnosing patients. For example, if a patient comes into the clinic and only has lesions in non-sun exposed areas, along with lesions varied in size and shape, and persistent or progressive patches or plaques, these are common findings for MF and not typical of psoriasis or atopic dermatitis. A skin biopsy is important for the diagnosis of MF. When a skin eruption is persistent and doesn't respond to typical treatment and/or has characteristics suggestive of MF, then a skin biopsy would be indicated. The dermatologist usually performs an incisional or excisional biopsy. Typically, the patient should stop any topical treatments for at least 2 weeks prior to a biopsy. Repeat biopsies may have to be done over a period of time. For instance, patients with MF may evolve from patches to plaque stage lesions. You may not get the final diagnosis in one type of lesion, but you may in another. You may get a diagnosis in a plaque, but not in a patch. You may find follicular tropism in one type of lesion and not in another. If a biopsy is negative, it's important to go back and ask these questions. Did you choose the right lesion? And did the patient stop treatment prior to the biopsy? Diagnosing MF can be a challenge, and it's not uncommon to need several skin biopsies in order to make a clear diagnosis. Yes, although sometimes physicians do a shave biopsy if it's a plaque or a tumor. The best lesion to biopsy is the most indurated one. The advantage of doing a punch biopsy is that you get to see the depth of a lesion in the dermis, if not subcutaneous tissue. I always do at least a 4 mm punch versus a 3 mm one. A 4 mm versus a 3 mm punch biopsy gives you enough tissue to do clonality testing if needed. If you do smaller biopsies, you may not have enough tissue to do extra studies to make a final diagnosis. I generally have a plan for all patients. Most patients are referred from a dermatologist or an oncologist who has performed a skin biopsy that is suggestive of MF or Sézary syndrome. I review the biopsy results, and if it's not definitive, then I'll recommend a repeat biopsy. We usually do our own biopsies for clonality because we collect skin samples on saline versus formalin and use next-generation sequencing versus PCR, which enhances the ability to find a positive result. Also, we always check the clonality in the blood or any other tissue involved to see if it matches the skin. This is particularly important when considering if blood involvement is present. I make sure we take a biopsy of the most aggressive appearing skin lesion as well as biopsies of other types of skin lesions, including any suspicious subfollicular involvement. As far as laboratory evaluation goes, I always do a complete blood count with differential, comprehensive metabolic panel, and lactate dehydrogenase test, and then flow cytometry and blood clonality tests. Many physicians would not do flow cytometry and blood clonality testing for patients who come in with presumptive stage 1A disease, but I have found a positive blood clone and minor blood involvement in patients with minimal skin involvement and no lymph node enlargement on physical exam. So I feel that it is reasonable to screen for potential blood involvement at the time of initial diagnosis of MF, regardless of skin stage. I always perform a thorough physical exam. If there's any suggestion of adenopathy, or if patients have widespread patches or plaques, tumors, or erythroderma, then I would order a CT or a PET CT. I always do photographs, which are critical, really, in terms of following a patient's skin disease. Diagnosis can be very challenging. particularly in patients with patch stage disease who don't have a clone in the skin, which can happen very frequently. In this case, it may be very difficult to separate out early MF from an atypical lymphocytic infiltrate. Clinical judgment is so important. I think having multiple skin biopsies can overcome challenges in diagnosing MF or Sézary syndrome. If your clinical judgment is that this patient probably has MF and you just can't prove it, then repeat biopsies of different kinds of lesions would be helpful. A biopsy of an enlarged lymph node may also be helpful in establishing a diagnosis of MF or Sézary syndrome. I work with a multidisciplinary team that includes a radiation oncologist, an oncologist, other dermatologists, and a dermatopathologist. We also have a multidisciplinary conference that is available anytime one of us has a question. If a patient comes in with aggressive late-stage disease or bulky adenopathy, they usually get an immediate referral to my oncology and radiation oncology colleagues for systemic therapy, which could include a targeted antibody or chemotherapy. We will discuss together what agents to use and if radiation is needed to debulk tumor lesions first, or if the patient needs total skin electron beam first. For most patients, even those with blood and limited nodal disease, a trial of immunomodulators is preferred first over chemotherapy. These are cancers without a cure, and the goal is to control the disease as long as possible with agents that do not leave the patient with long-term adverse effects. It is important that all patients have available to them a multidisciplinary team, a team that is experienced in MF. I think that's key. There's a benefit to having a low threshold for sharing patients among the group, and I think we have that. We readily talk to each other if there's any concern about a particular patient. I think that dermatologists see things related to the skin that are not apparent to other specialists who are not looking at skin all the time. For example, I had an African-American patient with MF who needed a kidney transplant. The transplant team requested that his skin be clear of MF before they would proceed with the transplant. The oncology group had determined he was clear, but when I saw him, he had diffuse skin involvement. The dry, scaly skin, which looked like xerosis without any inflammation, was determined to be MF upon biopsy. He was treated with total skin electron beam and interferon, which cleared his skin of MF, and then he went on to a successful transplant. Dermatologists are experienced in the multiple ways MF can present and have antenna up when something looks unusual. We treat many types of skin conditions and are familiar with how lesions present in different skin colors, so we can distinguish when something is not MF and is concerning for another condition. Certainly, any patient with a biopsy suggestive of MF would benefit from being seen and evaluated and having a diagnosis confirmed and treatment options outlined by a center of excellence. In any case where there are concerning skin lesions and a skin biopsy showing an atypical lymphocytic infiltrate, it's good to refer to a center with expertise in MF and Sézary syndrome. I know a topical has failed when the patient develops many new lesions in the treated area, or lesions have spread to such a large area that treatment with topical medications would be a total body treatment. If using skin-directed therapies, you would like to see that the plaques are becoming patches and eventually clearing, ideally within 3 to 6 months. If there's some improvement but not total, then considering adding or substituting a systemic agent would be indicated. Blood involvement is an important factor for prognosis and symptom control. The blood involvement needs to be brought under control, not just the skin disease. MF and Sézary syndrome can involve multiple compartments, and selections of appropriate treatment need to consider the compartments involved and the extent of involvement.
Indication: POTELIGEO mogamulizumab-kpkc injection for intravenous infusion is indicated for the treatment of adult patients with relapsed or refractory Mycosis fungoides, MF, or Sézary syndrome, SS, after at least one prior systemic therapy. Important safety information, warnings and precautions. Dermatologic toxicity. Monitor patients for rash throughout the course of treatment. For patients who experienced dermatologic toxicity in Trial 1, the median time to onset was 15 weeks, with 25% of cases occurring after 31 weeks. Interrupt Poteligeo for moderate or severe rash, grades 2 or 3. Permanently discontinue Poteligeo for life-threatening grade 4 rash, or for any Stevens-Johnson syndrome (SJS) or toxic epidermal necrolysis. 10. Infusion reactions. Most infusion reactions occur during or shortly after the first infusion. Infusion reactions can also occur with subsequent infusions. Monitor patients closely for signs and symptoms of infusion reactions and interrupt the infusion for any grade reaction and treat promptly. Permanently discontinue Poteligeo for any life-threatening grade 4 infusion reaction. Infections. Monitor patients for signs and symptoms of infection and treat promptly. Autoimmune complications. Interrupt or permanently discontinue Poteligeo as appropriate for suspected immune-mediated adverse reactions. Consider the benefit-risk of Poteligeo in patients with a history of autoimmune disease. Complications of allogeneic HSCT after Poteligeo. Increased risk of transplant complications have been reported in patients who received allogeneic HSCT after Poteligeo. Follow patients closely for early evidence of transplant-related complications. Adverse reactions. The most common adverse reactions reported in greater than or equal to 10% of patients with Poteligeo in the clinical trial were rash, including drug eruption, 35%, infusion reaction, 33%, fatigue, 31%, diarrhea, 28%, drug eruption, 24%, upper respiratory tract infection, 22%, musculoskeletal pain, 22%, skin infection, 19%, pyrexia, 17%, edema, 16%, nausea, 16%, headache, 14%, thrombocytopenia, 14%, constipation, 13%, anemia, 12%, mucositis, 12%, cough, 11%, and hypertension, 10%. You are encouraged to report suspected adverse reactions to Kyowa Kirin Incorporated at 1-844-768-3544 or FDA at 1-800-FDA-1088 or fda.gov/medwatch.